At the outset, I'm very glad to be here on this platform once again. Could you see my screen?
Yes, we can. Can you make it full?
Yes, just. Okay, so I will be talking on the functional tumor volume at 3 and 6 week MRI as an indicator of patients with inferior outcome after neoadjuvant chemotherapy. So the study was presented as a part of the I-SPY trial, which is the investigation of serial studies to predict the therapeutic response with imaging and molecular analysis. So this trial has been conducted in phase 1 and phase 2 stages. It is presented by the authors of Onishi et al. At the San Antonio Breast Cancer Symposium. So talking about this trial, the background which is known is that we know that there is a response to treatment on chemotherapy prior to surgery. The idea is to identify patients who are undergoing an MRI and predict a response. So this study aimed to develop criteria based on the MRI tumor response to identify patients early on in their treatment who are on a trajectory to an inferior response as reflected by residual cancer burden. So there is an escalation strategy which is going to be used, and it is being used in the I-SPY 2 trial. And this is for a treatment option to redirect the potentially more effective therapy for patients likely to have an inferior response. So there is a pre-treatment MRI, and then those which undergo a poor response do have a week 3, week 6 MR, a week 12 MR, and then a pre-surgical MRI. The database behind this is a randomized control trial where they are adding the routine paclitaxel regimens for 12 cycles followed by other regimens, which is the standard arm, and the control arm is going to have many more new added chemotherapy agents to look at personalized medicine response. So MRI analysis is a subset of this larger ongoing randomized control trial. The background for defining what is residual cancer burden is that this is a post-neoadjuvant chemotherapy, post-surgery histopathological evaluation of the tumor volume or the tumor burden, also known as the RCB. It is established as a surrogate for predicting the survival outcome. So to look at the disease-free interval or the relapse which is seen over time at the distant sites as we go ahead with time, it is most poor in cases with an RCB3, which identifies a higher residual cancer burden. This was presented in the JCO, and it defines RCB0 as complete pathological response, which reflects a very good survival or disease-free interval in terms of disease management over time. And RCB1, 2, and 3 would be reflecting the tumor volumes, which is representing the increase in the tumor burden. The 2 and 3 show an inferior outcome, as is seen over here, with much more poorer outcomes seen in RCB3. For the treatment escalation option, patients likely to result in this category will require an earlier detection while they are on their standard neoadjuvant chemotherapy protocol. The purpose was to investigate the ability of a combined 3 and 6 week FTV, that is tumor volume, based criteria to detect RCB2 or 3 patients as candidates for the treatment escalation option. The number of patients taken were 104. They underwent an optional 6-week MRI between Jan 18 and March 21. The FTV reduction at 3rd week and 6th week MRI was compared. The methodology is to determine the functional tumor volume. This is obtained by analyzing the quantitative measurement of tumor burden derived from dynamic contrast enhanced MRI. And it was measured during the chemotherapy at various time points. The first one was prior to embarking the therapy, which was a T0. There was the first MRI after onset of chemotherapy at 3 weeks, labeled as T1, at 12 weeks, labeled at T2, and pre-surgical MRI was performed, which was T3. Now over here, an interposed MRI was taken up at an optional phase at 6 weeks for patients with low response at 3 weeks, and this was termed as a T1A in the time point manifestation. So what they then did was there was a dichotomization of the data in which analysis was done at 3 week and at 6 week, and the reduction from T0. So T0 is the time point prior to embarking therapy. The volume estimated was your T0 volume. From that, they would calculate the difference in the percentage of response. So a 20% response. So each was further dichotomized into less than 20% response, which would be very poor responders, or more than 20% response. The dichotomization for a 6 week happened at 65% difference of response, less than 65 or more than 65. After this, the cancer burden after neoadjuvant chemotherapy was termed as either a responder under 0-1 category or a non-responder, which was phase RCB 2 and 3 category. The statistical analysis was calculated by Fisher's exact t-test and the positive predictive value and sensitivity. The association between the tumor volume reduction and the residual cancer burden outcome was seen in 104 patients. Out of these, 49 were included with RCB and an analyzable FTV. A subset analysis of these was such that 31 out of these 49 patients were hormone receptor positive and HER2 negative. 16 were HER2 and HR negative, and 2 were HR positive and HER2 positive as well. So looking at the analysis, this was a volume, which was a relative volume compared to the time from the treatment that started. So we have a 6-week, 12-week, 18-week treatment. The MRI was performed at T0, which was MRI 1. There was a T1 MRI at the 3rd week. T1A was an optional 6-week MRI, and T2 was a standard MRI performed at the 12th week. So what they analyzed was from the onset of 0, there were different curves and graphs that were obtained. RCB 0 are the ones marked in blue, and the ones marked in greens are 1. So these were essentially responders, and they showed a very good rapid drop in the tumor volume after the initiation of chemotherapy. However, looking at the browns and the pinks, which were the poor responders, they observed that there were a fair amount of patients which did not undergo response at the 3rd week and subsequently at the 6th week. So an analysis was performed individually at the 3rd week and the 6th week. And what was observed that at the 3rd week, out of the 49 patients, 26 patients had very poor response with less than 20% reduction marked by the brown lines. So what we do see here is there is a poor response in a little more than half the number of patients, and a little less than half the number of patients underwent a very good response of more than 20% reduction. This gave a positive predictive value of 73% and a sensitivity of 68%, which was good. Now looking at the 6-week data, at the 6-week data, what was observed that we have n equals to so what we do observe at the 6-week data is that compared to the earlier 3rd week data, at the 6th week, n equals to 30, patients had a poor response of less than 65% reduction, and more than 65% reduction was observed in 19 patients. Hence, the patients who underwent a poorer response, some of them did show a good response later and continue to have a poorer response eventually over time. This had a positive predictive value of 80% and a sensitivity of 86%. So at 6 weeks, we had a better predictive values with us. Looking at a comparison of the poor responders, which were less than 20% reduction in the first category at T3, that is at the 3rd week, were compared with a combined analysis at the 6th week. So the 3 and 6 week combination showed that of the poor responders, 22 patients continue to have a poor response even at the 6th week, whereas some patients had an improvement in the response beyond the 3rd week up to the 6th week. This combination had an improved specificity, sensitivity of 95% and positive predictive value of 82%. So various cutoffs were analyzed where the entire subset of patients who underwent a poor response on T1 were analyzed at T1A, and they saw the response at less than 45% reduction, less than 50, less than 55, 60, 65, 70. So looking at various percentages of response among the poor responders, the best sensitivity and a combination of a good positive predictive value was obtained at a T1 of less than 20% reduction and T1A of 65% cutoff. So this is a fairly good analysis, and the conclusion was that statistical significant association was shown between the RCB outcome and FTV reduction at 3 and 6 weeks. A combined two-step criteria using FTV reduction at 3 and 6 weeks showed a high positive predictive value and sensitivity in early detection of non-responders. An optional use of 6-week MRI in this study may have introduced bias. Currently, they are requiring 6-week MRI for all patients with a limited early response, and the combined criteria will be further tested and refined in a prospective cohort in I-SPY 2. They do advocate that early prediction of non-responders will help physicians to identify patients who are not benefiting from their current therapy and redirect them to a different therapy or an added therapy that might work better for them. These are their acknowledgements. There is a good meta-analysis to look at, does an MRI perform well? Yes, an MRI performs very well in evaluating the pathological response to neoadjuvant chemotherapy in breast cancer. This is the data of almost close to 1,000 patients. The take-home message that I would say is that yes, MRI does predict pathological expected response. It is a road to personalized medicine. Not all patients planned for surgery undergo an MRI in our country. So we do need to look at a judicious choice of which patients are going to undergo and benefit from this category of evaluation in the management pathway. It would be good to triage the clinical non-responders and they undergo an MRI rather than every patient undergoing an MRI who is posted for NACT. And of these patients who do not respond after the after the 3-week period can be subjected to an MRI and then further interpolated data to T1A, T2, and T3 as proposed by the trial. Extrapolating response to findings on CCT would be of an extreme high worth because CECT is yet today in our times done for all patients, whereas an MRI is available only for a very small cohort of patients. Thank you so much.